Buenos días a todo el mundo. Muchas gracias por venir al seminario de Jacek. Voy a hacer una breve introducción y luego cambiamos al inglés, que es el idioma en el que Jacek va a dar la charla. Eh, a ver, tengo aquí de introducción. Bueno, ya mandamos algo en el flyer. Jacek consiguió él es MD PhD, así que consiguió el MD la Medical Academy de Lublin en el 99, luego consiguió un PhD en Medical Sciences en inmunología, específicamente en el 2004 en la misma universidad. Ha trabajado en bastantes enfermedades distintas, siempre desde el punto de vista del aspecto inmunológico. Ha tratado la osificación heterotópica, la artritis reumatoide, pero también el cáncer, por ejemplo. En el 2020 lo nombraron profesor total, full professor, y aquello es algo muy relevante en Polonia, de donde él viene, porque es el presidente de Polonia el que viene a nombrarte catedrático. Hoy en día es catedrático full professor en el Departamento de Human Immunology y Medicina Translacional en la Universidad de how would you call your university?
University of Rzeszów.
Rzeszów. Donde hasta 2019 fue incluso el director del centro. Ha publicado más de 400 papers, dirigido tesis de máster, de PhD y dirigido ensayos clínicos. So now I'm going to switch into English just to empathize with you a little bit. I got to know Jacek through a joint European grant application that we were involved in. He's in charge of taking care of patients with a very rare bone disease that I work with in Poland, and that's how we ended up working together. Is visiting us now for 5 days together with Olivia. They are just looking at what we do in the lab and how we do it, thanks to the Erasmus Plus program. So if you want to talk to him or you want to discuss something in particular, or even just drop him an email, you can surely do it until Friday, because he will be flying back on Saturday morning, I think. And now I leave you with his talk. I hope you will enjoy it. Thanks so much. Please, the floor is yours.
Okay. Welcome everybody here in the hall and also online participants. And first of all, I would like to thank you, Gonzalo, for opportunity to come here to Oviedo, to his lab, to your institution, and also to have the opportunity to give this lecture. Okay. I try to switch because I don't see the presentation.
They will try to learn from there.
Okay.
It's his fault. Apparently, we didn't do anything.
No, the point is that there was people trying to fit in. Sorry. I'll do it again. So can you accept that?
Okay, so I can talk. I remember the slides, and there is nothing interesting in these pictures. Yes, in the first slide is a simple introduction. So the title of my speech will be the immune response in the autoimmune arthritis. Are we always at the same page? And why I chose this title, and I want to talk to you about a little about this autoimmune arthritis, and do we shall think about the one disease and what are the difference, because I think we shall not thinking about the autoimmune arthritis and associate it only with rheumatoid arthritis. So here are some a bit of my conflict of interest, but nothing with this presentation, because today we will be not talking about the treatment or the medical software. As Gonzalo has said, I am MD PhD, and I'm working both in the basic science or preclinical science, and I'm working also in the hospital like every MD, and I take care about the patient, the pediatric patients. As you can see, I'm working in the pediatric clinic. So This is also the reason why I think we shall consider different type of arthritis on the different way. Okay, so if we are thinking about the immune arthritis, you are interested in this, you want to start your research, you are MD students or you are a doctor and you want to find something like this. Frankly said, what we do, we take our phone and Google it. Yes, this is what we usually do this time. So when you put autoimmune arthritis into Google, there will be fine definition. Of course, AI try to help us. We want or we don't want it. It helps us and okay. So usually you put the phrase autoimmune arthritis to your Google and okay, this is I do this probably with
No. It's people just too late.
No,
because the
Aproximación.
okay, yeah. So you try to search the autoimmune arthritis, which is a very general term, and the Google return you everything about rheumatoid arthritis, which is one particular disease. So even if you want to have the fancy pictures for your presentation about the autoimmune arthritis, you try to search it in the internet. All the pictures will be probably about the rheumatoid arthritis, no autoimmune arthritis. Yes, and you can find another pictures which show you the types of the arthritis, and again, they expose the rheumatoid arthritis and something like juvenile rheumatoid arthritis. And frankly say, if I see it as me, as a pediatrician working in clinic, or I'm an immunologist, so maybe not. So I'm not annoyed so very, but my colleague pediatrician and rheumatologist will be very annoyed with this picture because there is no such a disease like juvenile rheumatoid arthritis, because this is juvenile idiopathic arthritis. Why it's so important for us and why it's so annoying? Because in general, in medicine, but also in the research, people are thinking they are the same diseases. And frankly say, for example, I was working always with the collaborate and working in the pediatric clinics. I make some research about juvenile idiopathic arthritis. I submit my paper and reviewer says, no, reject it because this was done or similar paper was done in the rheumatoid arthritis. So they doesn't consider they are completely different. This maybe not completely, but they are different. Yes, because usually arthritis is counted to be rheumatoid arthritis. And to my surprise, I put these phrases to the PubMed. As you can see, autoimmune arthritis is a very general phrase. Yes, it shall show us papers about any arthritis with the autoimmunity involved in the pathology, but this is only less than 40,000 records. Yes, when you put the autoimmune arthritis, so very general term. When you put rheumatoid arthritis, it's like over 181,000 records in return. So you put something more detailed and get more records than you put something very general. It's surprising. When you put the juvenile idiopathic arthritis, is something like less than 80,000 records. So 10 times more, 10 times less than in rheumatoid arthritis. And this is probably why, because, as I have said, people are thinking that rheumatoid arthritis and juvenile arthritis are the same disease and don't like the new papers about juvenile idiopathic arthritis. If similar papers based, for example, on the same method, on the same genes, on the same cells was published in the rheumatoid arthritis. So why the rheumatoid arthritis is so popular and so well known, and many researchers are focused on rheumatoid arthritis. It's not only about the demographic that you have more adult patients and the pediatric patient affected with the arthritis. But why? Rheumatoid arthritis is well-defined disease. I don't say there is the easy disease for the doctors. This is easy disease for the patient, but it's well-defined. Here what you have the diagnostic criteria. As you can see, there were changes in 2020. This is also worth to notice. And you have the scale, you check the patient, you fulfill these points, You fulfill these points, and if the patient have the 6 points or more from the 10, you can diagnose the patient with rheumatoid arthritis. And also for researchers, it's very good because you have the very homogeneous group for your study. Yes, they don't differ much. They can be more or less active disease, but all fulfill the same criteria. So very homogeneous group, nice to study. And when we are thinking about the juvenile idiopathic arthritis, again, if you are not into the GAA, you are thinking about the one disease, which can be compared with the rheumatoid arthritis, but this is not. This is very heterogeneous group of the idiopathic inflammatory arthritis affecting pediatric patient. Sometimes you can find this is the bag or umbrella when you put any arthritis affecting children without known cause. Yes, and look at the diagnostic criteria. In rheumatoid arthritis, you have the very precise, you give the points, you diagnose the patient. In our work, in our clinic, we're working with children, what are the diagnostic criteria? Younger than 16 years of age. Okay, children. Lasting 6 weeks or longer, so the inflammation must be chronic. Okay, and the last, we shall exclude other causes of arthritis. No points, no markers, nothing specific. Yes? So you can imagine how heterogeneous these patients are. And it is also shown by classification. Yes, and why I tell you to look at this criteria from 2020 in rheumatoid arthritis. The criteria for juvenile idiopathic arthritis are from 2001. So it means over 20 years, no one changes in this, yes? And they keep this criteria, and you see how many type of arthritis can be called juvenile idiopathic arthritis. We have most common oligoarthritis. We have the polyarthritis with 2 subtypes, and one is rheumatoid factor positive. And there is more or less, we can say this is juvenile rheumatoid arthritis because the patients are similar to this patient with rheumatoid arthritis. But you have systemic arthritis, and this is, we will talk about this later. We have psoriatic arthritis, also included into GAA. And as you remember, you exclude the patient with psoriatic arthritis from rheumatoid arthritis. And also we have the enthesitis-related arthritis, which will be more or less like, again, different disease in adult patient, ankylosing spondylitis. And we have the other one, undifferentiated arthritis. So if you have the children with arthritis, 6 weeks, you cannot find that it is reactive, it is infectious, it is associated with some syndrome like the multi-disease syndrome. This is also GIA. So now you can imagine how your heterogeneous group of the patient is. It's not good for your study. Yes, because, for example, you will use the samples only from the most common form like oligoarthritis. You submit your paper and what reviewers say. Okay, you check only one type. Why you don't include the polyarthritis? Why you don't include the systemic arthritis? When you include all this group, probably the reviewer will say that your results are not homogeneous, are not coherent, because you find something in one group which is completely opposite to another group. And it will be probably when you have the patient with systemic arthritis included to your group. And I will talk later why this systemic arthritis is so different. And I can just give you a clue, it's because of this classification. So this is not very rare disease. Frankly, so it's the most common rheumatological disease in children. We have a lot of patients. And as I mentioned, the majority of them is oligoarthritis. Here we have also monoarthritis, because, for example, children very frequently can suffer only inflammation in one joint. And this is completely opposite to the rheumatoid arthritis, when usually you see you have multiple joints to be affected by the disease. And this systemic arthritis is not so rare. And frankly say that this RF positive polyarthritis is one of the rarest, which is, as I have told you, very similar to the rheumatoid arthritis. And also we have some differences in different sites of the world, geographical differences. And here I find one of the comparison of GIA and rheumatoid arthritis on one of the, let's say, the scientific web page. So two obvious difference, children, adults. Yeah, okay, this is very obvious, nothing to discuss. Yes, 6 types, single condition, as I told you. Yeah, and this is may go to remission, may be chronic and last their lifetime. And this is some kind of the misunderstanding, yes, because frankly in the internet you can find that the children can outgrow the juvenile idiopathic arthritis or they go to the remission. This is true, but this is again different criteria. Because, for example, in RA, when you have we call it adult rheumatologists, they are thinking about the low activity of the disease. Yes, here we have, in the pediatric patient, we have the remission. But remission is not that, it doesn't mean that patient is cured. We bring with the immunosuppression patient to the not symptomatic condition. Okay, it can last 1 year, it can last 2 years, in some patient it can last 1 month. And it is depending also on environmental condition. For example, after COVID, we have many exacerbations in the patient who were in the remission for 1, 2, 3, even 5 years. And after COVID, we have the massive increase in the patient number because this virus activates the immune system and also activate the autoimmune response. And the third difference may cause the growth problem, do not affect the bone development. Frankly say, because they are adults, yes, so how it can affect the bone development? They develop the bones, they don't grow anymore. So this is obvious that this is the difference, yes, that the children are growing and the inflammation in the bones, in the joints can induce some problems with the growing or sometimes overgrow of the cause of the bone and sometimes stop the growing. And this is also the problem, which I can show you something like our clinical kitchen, because there was the one study which confirmed that about the 56% of the patients affected with GIA can be diagnosed as a rheumatoid arthritis. And this is quite funny if you are not familiar with the clinic. Why is this problem? Yes, because this is, for example, juvenile arthritis, this is pediatric disease, but our patient go over 18. And what happened? For example, they go to the rheumatology clinic for the adults, and I don't know how it's in Spain, the healthcare system, but for example, in Poland, this clinic cannot take care about the pediatric patient or patient with pediatric disease. Yes? So what happens? They change the diagnosis to rheumatoid arthritis to treat the patient. Yes, so it's like a magic. Yes, you turn 18 and yesterday you were affected with juvenile idiopathic arthritis. Today you are affected with rheumatoid arthritis. And it brings some problems and I will show you. And this paper is very nice. And they check this if the patient are affected, but they do something what is done only research. I never have seen such a procedure in the real life, everyday life. Why? Because they have adult patients, but what they use the juvenile arthritis damage index. So the scale, the procedures used for the pediatric patient. Why is so important? Here you have this homunculus and how you check the disease activity in the patient. This one is homunculus used for the DAS28. It is common scale used to check the activity of the rheumatoid arthritis in adult patient. You check only 28 joints. Yes, and this one is used in our clinics every day. It says JDAS 71. It means we check 71 joints in children. Yes, you can see. For example, in DAS 28, you don't check the ankles, you don't check the small joints in the feet. And what happens when the patient comes with GIA, but is 18 and go to the adult rheumatologist? Oh, sorry. Okay. Okay. Here shown the diagnostic criteria for rheumatoid arthritis. He checked, for example, the patient with affected 2 ankles and 2 small joints in the feet. So 4 joints are affected. Patient is suffering. In the DAS 28, 0. Yes, because they cannot put this into calculator of the disease activity. And this is very common problem with our patient which becomes adults. They go to the rheumatology clinic, they use the DAS 28, they say, okay, this patient is not affected or this low activity of the disease, and we cannot treat this patient. Yes, because the score is like 0 or 1, and you still need to treat the patient with the score, they say, after 5. Yes, and this is the problem. And for example, in Poland, in our hospital, we solve it that pediatric rheumatologist is also taking care about the adult patient with GIA if they want to continue this care. Because in Poland, we don't have the differentiation between the adult rheumatologist or pediatric rheumatologist. If you are a rheumatologist, it depends what clinic you choose. Yes, you want to work with children, you go to the pediatric clinic. You want to work with adult, you go to the adult. So they can do this, take care about the adult patients in outpatient clinic. Yes, because, for example, if they become severe patient, we cannot take them back in our ward because we cannot hospitalize the adults in the pediatric clinic. But this is the problem. And my title is immune response. So we go slowly to the immune response, but I would like to show you why I'm talking about these differences. So what are the differences and what are similarities? Generally, in almost all autoimmune diseases, the cause is unknown. Yes, we don't know precisely in the majority of these diseases, we don't know precisely what antigens induce the reaction, what are the conditions which trigger the disease. Yes, we know there is some genetic predisposition, there is some environmental factors. So when you look to this definition or this text about the etiology, it seems very similar to rheumatoid arthritis and juvenile idiopathic arthritis, but we always ask the question, so why? If they are very similar, why these diseases affect the children, even very small children like 1-year-old, 2-year-old? And these diseases affect usually the elder person. Yes, like I'm not trying to offend anyone, but elder patients after 40 or after 50, yeah, so yeah, or even older, yeah. So why it happens? It can be these trigger factors are probably not the same, or the predisposition are probably not the same. Of course, you can look to using the whole genome sequencing, and you find the HLA allele which predispose to the disease, and you can see they are pretty the same. In general, they are based on DRB1. Why? Because DRB1, this is the molecule with the high affinity to the citrulinated peptides, and presented with the very high affinity and stimulate the T cells. So these allele are the same, predisposing to the RA and to the B1. Here you can find another, but for example, HLB27 is in GIA, and not in array because this is the HLA molecule predisposing to ankylosing spondylitis. So simply say then don't list it in the adult patient because they have different disease associated with this molecule, and there is very strong association, like as 95%. Yes, people with HLA-B27 are affected with ankylosing spondylitis or another enthesitis. So no big difference here in the MHC predisposition. And what I told you that this DRB1 express high affinity to the citrullinated peptide. Why is so important? Because these citrullinated peptides are presented to the T cells, which after that activate the B cells. It's obvious. And in the rheumatoid arthritis, we have intensive production of ACPA. So this is general named for the antibodies against the citrullinated peptides. And if you remember, there was the one criteria for the diagnosis of rheumatoid arthritis. And if you have the high concentration of these antibodies or rheumatoid factors, you get the 3 points. So this is worth the half of the minimum value to be diagnosed with rheumatoid arthritis. So it means express the strong association, strong predictive value, and also strong value to monitor the ACP concentration during the therapy because it is correlated with disease activity in rheumatoid arthritis. And how it starts, that the peptides are citrullinated and induce the reaction against the synovial membranes and cartilage and other elements of the joints. It is supposed that everything is associated with the mucus-associated lymphoid tissue. So it starts in the guts, lungs, or in your oral cavity. Rheumatoid arthritis is strongly associated with periodontitis, so inflammatory condition of gingiva in your oral cavity. And this is the first difference also between RA and GIA. Generally, periodontitis is not common in children. We start such a product to check the function of the oral mucosa immune system in children, and we have such a problem that we cannot access the periodontal space in children. Yes, in adults, you put the paper between your tooth and gingiva, and it takes the fluid, yes, and you can measure cytokines, you can measure any protein which is in this fluid. In babies, our dentists say we cannot put this paper because this space is so close, because you don't have the periodontitis. So this is the first difference between RA and GIA. This induction of this pathological immune response doesn't happen in the mouth, probably. Also, children rather don't smoke, they didn't have the COPD. So lungs are also not the starting site. So what is in common? Because as I have told you, we have some similarities and some differences. Our digestive tract, and this what is very also popular in the research, the dysbiosis or abiosis, so that what can lead to this abiosis and what these two types of arthritis have in common. Okay, also about this ACPA. In rheumatoid arthritis is a lot of the research, so they were able to identify some also antibodies to the native antigens, because these antibodies are not produced only to citrullinated peptide, but because of epitope sharing, they are also produced to the native antigens. And as you can see, for example, in one study, they find 27 different autoantibodies correlated with the disease activity. So it means they are really associated with the disease. And what about the mucous membrane in our digestive tract? Both of these type of arthritis are found more frequent in the patient with some immune pathologies, which are based on the decreased concentration of IgA. So it means that this type of the immunoglobulin, which is released in our mucous membrane. Frankly say we released, it is something surprising, something like 5-7 grams of antibody to our mucous membranes, mainly in our guts. So 5-7 grams, it's just like a spoon of whey protein concentrate, something like that, yeah? And in rheumatoid arthritis patients, we can find common variable immunodeficiency. It's a condition based on the disturbance in production of immunoglobulin, AGA, IgG, the mainly. And this is the immune deficiency usually diagnosed in the patient over 30. Yes, usually there is the congenital condition, but usually the diagnosis is set in the adults. So not in the children, but in the children we have the selective IgA deficiency. They are the children who doesn't produce the IgA at all, or they produce very, very low concentration of them. Also, the children before the age of 4, this is normal, they produce low amount of IgA. So it means they don't have the good, these adults and these children, they don't have the good protection against the interstitial bacteria. And it can lead to the dysbiosis. So probably both these types of arthritis are associated with some problems with the immune response in digestive tract, especially the low concentration of IgA, and this is in common. Yes, so mucous membrane can be involved in both of them. Okay, so here is the summary about the role of antibodies in both types of arthritis. So rheumatoid arthritis is clearly associated with the production of pathogenic, primary or secondary pathogenic antibodies, rheumatoid factors. These ACPA or anti-CCP antibodies, and also antibodies to the naive antigens, and we have the dozen of study about this in array. Yes, RF can be found only in the small group of the patient with GIA. So despite this is rheumatological disease, we don't find the rheumatoid factors in the children. It's very rare, and it's usually found only in this patient like RF positive polyarthritis. So it means that, let's say, pediatric rheumatoid arthritis or juvenile rheumatoid arthritis. Also, we cannot find almost these ACPA antibodies in children. Frankly say, when we have dozens of the new cases in our clinic each year, if we find one sample positive for ACPA in juvenile arthritis, it is something what we show in each other. Yes, that we have the ACPA positive juvenile idiopathic arthritis, so it's extremely rare. So this is the huge difference, yes, in the starting disease and depending on antibodies. But I will not say that GIS is completely independent from production of autoantibodies. We don't have such a nice study. Again, only one study of the group which detects 18 antibodies against the native antigens, but they didn't confirm any association with the disease activity, etc. Because this is, again, only one study which I was able to find. What we frequently find in the pediatric patients, they are ANA antibodies, antinuclear antibodies, but we don't know specificity of these antibodies. And based on my experience, yes, if the patient express the high concentration of antibodies and even have the hypergammaglobulinemia, so it means the high amount of IgG in the blood, this is bad prediction factor. Probably this patient will suffer more, will be more severe patient, and we have some problem with induction of remission in such a patient. But it's a completely blank field. Yes, you can open it. If you are able to check the antibodies profile, to check the antibodies to the native antigens in GIA, yes, it will be really nice work. If you will do this, send to the paper as someone rejected because it was done in rheumatoid arthritis, suggest me as reviewers, and you get the positive review. Yes, because we are lacking of such papers. So if the disease is associated with antibody, it has to be associated with B cells, and of course, the B cells are associated with the pathology of rheumatoid arthritis. The source of these activated B cells still is unclear, but there are some suggestions that, for example, they can come from the inflamed lung, especially in the patient with immune deficiencies, because the pneumonia is common in this patient. And in array, the results of research suggest that the pathology is associated with the aging of the B cells. Yes, and this is why the disease occurs in the adults, and even adults over, let's say, generally 50, but nowadays also over 40. Yes, because these aging B cells, when they interact with the T helper, Th1 cells, are switching to be very immunogenic, not only because of the presentation of antigen, but they start to release a lot of the interferon gamma and another cytokines which push the immune system to the Th1 differentiation, which is more destructive than another types of Th response, like Th2 or even Th17, because this is cytotoxic immune response. It's based on the killing and destruction of the tissue and cells. You can find some papers which put the B cells in the central of the pathogenesis of rheumatoid arthritis. Okay, they are important. My personal opinion is that they are not in the center. They are crucial, but not in the center, because they are not so strong antigen presenting cells to induce very strong immune response. We are after that we are going to the dendritic cells. We are much potent antigen presenting cells and present huge variety of the antigens. And of course, in both type of arthritis, we can count that regulatory cells are disturbed. There is in the repertoire, in the number, or in the function. So BRAX pathologies are also found in the array, and only few studies in the juvenile idiopathic arthritis, as always. So what can happen with the B cells in juvenile idiopathic arthritis, the disease which can occur even if the first year of their life? So what is suggested that this problem lies in the bone marrow. And during the development of the B cells, some clones are expanding and the stage of the development in the bone marrow, and they react to the autoantigens. They are missing regulation, and they can start produce this antibody, which we don't know the specificity, we are not able to use them in the diagnosis or prediction. Yes, because of the lacking of research of this. Now we start some research based on the checking the bone marrow of the children with GAA. And we are hoping we finish this project next year, and maybe we'll have some answer what happens in the bone marrow of the children with different types of the juvenile idiopathic arthritis. So generally, the function of the B cell in both types of arthritis is similar. Expected production of these rheumatoid factors and ACPA. And also in both diseases, we have the also strange phenomena that the B cells can produce protective antibodies. It means that, for example, these are the antibodies which cover the antigens expressed on the cells and hide these antigens from the T cells, especially cytotoxic T cells. Yes, they cannot recognize this protein on the cells and kill these cells. And this conclusion based on the experiment in mice model that they select these known antibodies from the patient with rheumatoid arthritis, induce the production of antibodies to the same antigen in the mice. And when they inject particular antibodies directed against the particular antibodies, these mice didn't develop the collagen-induced arthritis, which is the model of rheumatoid arthritis, mice model of rheumatoid arthritis. So maybe in both diseases, we have the production of protective antibodies. So antibodies are not only pathogenic, but also can be protective. T cells, yes, because the T cells are obvious the key players. Yes, they are playmakers in the arthritis and also in any autoimmune inflammation. So generally, when they are activated by dendritic cells, and frankly say this is why I say that the dendritic cells are crucial, not the B cells. Yes, because they have strong potential to engulf antigens, present antigens, and okay, I'm also the dendritic cells guy, so I work a lot on the dendritic cells, and for many years they were my favorite cells. So they can activate the T cells, and after the T helper cells activate another type of the cells like B cells, synoviocytes, also the macrophages, but also directly influence the osteoblasts and osteoclasts and induce the destruction of the joints. Also, because of the number of places, we have many data about the role of the T cells in the array, also unconventional T cells like NK T cells, which strongly cooperate with the fibroblasts-like synoviocytes. This can be checked in vitro models. So this is inflammatory cells similar to the inflammatory synoviocytes, which lead to the permanent inflammation in the joint. Also invariant cells, and these invariant T cells can be found in the mucous membrane. So it confirms the strong association of rheumatoid arthritis with the immunity in the mucous membrane. And gamma delta T cells, which are rare population found in humans, but they increase, for example, the production also of IL-17, induction of unspecific immune response, so induction of the acute inflammation, and they also participate in the rheumatoid arthritis. Unfortunately, we don't have such a data from the juvenile idiopathic arthritis, so there are very general data that, okay, T cells are involved, especially Th1, Th17 cells, and they induce the inflammation in the joint. So in the summary, generally, the T cells are acting the same in both type of arthritis. We rather don't expect a big difference here, but again, if someone will check, probably these invariant cells or unconventional T cells, we can find a difference. Still, we are missing data in juvenile idiopathic arthritis. And dendritic cells, so my favorite ones. Generally, they are very potent cells. I don't know how familiar you are with the immunology and the immune cells, but usually when the students are answering questions about antigen-presenting cells, they say macrophages. Yes, because everyone knows macrophages. Just to show you, one macrophage can activate 100 T cells. Yes, it was some kind of the virtual calculation based on the life cycle and etc. One dendritic cells can activate 3,000 of T lymphocytes. So the power of this activation is not comparable between macrophages and dendritic cells. They are really generals of the immune response and cells which are able to induce strong reaction. So they activate the T cells, and the T cells in array, but also in GIA, release the cytokines which induce the overproduction of GM-CSF. And GM-CSF generate the inflammatory dendritic cells. And in this type of arthritis, you can find very strange dendritic cells which are developed from the monocyte. Because generally monocytes is a precursor for macrophages. Yes, but in this inflammatory condition, they induce in vivo so-called monocytes, dendritic cells or inflammatory dendritic cells. And I mentioned the difference. Yes, if monocytes differentiate into macrophages, can activate 100 lymphocytes. If pathologically differentiate into inflammatory dendritic cells, 3,000. Yes, so 30 times more. It is huge difference in the potency of activation of immune response. Also, they influence the differentiation to Th17, and nowadays, especially in rheumatoid arthritis, we use anti-Th17 treatment, so we can block IL-17, but we also can block the IL-23, which induce the Th17. In GIA, they are just baby steps with introduction of this treatment. Maybe in the US, they are more advanced because this is choice of the doctor, what you choose to the treatment, and insurance of the patient, of course, is influencing what you can use. And also in our system, we have tolerogenic DC, but in general, we don't find them in rheumatoid arthritis. We also didn't find them in the juvenile idiopathic arthritis. And also metabolism of these dendritic cells is changing in the inflamed joint and leads to the generation of these monocytes or inflammatory dendritic cells. As you can see, they expand Th17, which are potent stimulation of neutrophils and acute inflammation. And they also release a bunch more pro-inflammatory cytokines that conventional dendritic cells. And this is one of our study that we are showed that dendritic cells are accumulated in the synovial fluid of the patient with juvenile idiopathic arthritis. Even on the dot plots, you can see this is blood, the left column, and the right is synovial fluid. So there is huge difference in the number of dendritic cells they accumulate in the synovial fluid, and this is a bad prognostic sign, because this accumulation can even lead to the formation of ectopic lymphoid tissue in the synovial membrane. So it means that the disease is progressing locally without any control, general control of immune system, because we don't need, in general, we need the migration of T cells from the lymph nodes to the tissue. Yes, because they are activated in the lymph nodes and they do the job in the tissue. Here, if you have the local lymphoid tissue in synovial membrane, everything happens on the side. Yes, no migration, is huge proliferation of the T cell because of this local inflammation. And we are able to find any mature phenotype of the dendritic cells, and we were not able to find the tolerogenic dendritic cells in the synovial fluid of the children with GIA. And this is also our experiments. What we do, we take the healthy monocytes from the peripheral blood of the healthy individuals, and we add synovial fluid of the children with GIA. We don't add any cytokines, we just add the synovial fluid as a supplementation of medium. And we generate a lot of these MO-derived, monocyte-derived dendritic cells. Yeah, and we confirm the presence in the cell culture. I was a young PhD student this time, so I produced a fancy movie or something like that, because we get the confocal microscope, so we do such a things, make the color pictures, make the moving cells, or etc. Nice times, many years ago. And what we also see, that we have one type of the arthritis, systemic arthritis, when we don't have the increase of the dendritic cells in the blood. You can ask why in the blood we were talking about the synovial fluid, because this is called arthritis. But in many patients, you don't see the arthritis. You see another symptoms in this patient, systemic symptom, not arthritis. This is sometimes very confusing for the medical students and even young doctors. That we show, for example, we have the practical exam in the pediatrics, yes, and the students is showing the patient. The parents of the patient want to help students to say, my baby have the juvenile idiopathic arthritis, systemic one. So the students are checking all the joints, very good, but they found nothing. No joints are affected in this patient, but still diagnosis is arthritis. I will explain you later why, and why it's so confusing. So what is particular in this systemic arthritis? We go to this, but in the comparison, yes, they are the end. So very similar, and the last slide will be about this systemic arthritis. Because frankly say, if you remember this 2001 classification, they put new type of the arthritis in this classification, like systemic arthritis. Many years before it was called Still disease. And there is this discussion if the Still disease is autoimmune disease or autoinflammatory disease. Because no lymphocytes, no dendritic cell, the macrophage is a crucial here, and inflammation, unspecific immune response is crucial in the development of systemic arthritis. And this is very severe disease. Yes, because it can lead and it can evolve to the macrophage activation syndrome. It's a life-threatening syndrome, to the disseminated intravascular coagulation, to the histiocytosis, or multi-inflammatory syndrome, when your whole body is affected. And this is also seen in the dynamic of the disease. Generally, all type of arthritis, other type of arthritis are slowly progressing. In the systemic juvenile arthritis, the patient can progress in the hours. And we have seen, if they develop macrophage activate syndrome, their lives can be threatened like 5 hours or something like that if we don't start the treatment. So completely different disease, still called juvenile arthritis. Okay, and this is the last substantial slide. So in the array, we can make the fine picture of the crosstalk between the cells. And I hope in the next year, we can draw such a picture in juvenile idiopathic arthritis. There will be more research and more data to explain and find the very small differences even. Okay, so thank you for the attention. Here you can see our University of Rzeszów. It's hard to pronounce for not Polish people. So this is our main campus here and here. These two towers are not ours. This is Mordor. Yeah, it's over the river even. This is the center when our lab is placed. Myself and Olivia are working in this building. Frankly, this is my office. This fancy building is our sport hall, because in our college we have also sports sciences. They are focused on the volleyball and martial arts. So we have the bodyguards in our college. Okay. Sorry. You are invited to the Rzeszów and to our Subcarpathian area. Here you can see the old market in Rzeszów. The Subcarpathian area is full of the castles and palaces. And we are close to the Bieszczady mountains. Bieszczady, we can translate is devil smoke. Yes, because in the history, there was the production of the charcoal. And many smokes come from these mountains, and people were thinking that the devil is making this smoke. They are beautiful, especially in the autumn. And don't be afraid of this. I don't see such a winter in Poland for like 20 years. Yeah. This is very old picture, like from the 90s, probably, when we really were the northern countries. So thank you for your attention. Of course, if you have any questions, I will be happy to answer.
Good morning. Okay.
Good morning. Easy answer.
So, thank you, Jacek. Anybody has a question? Laura?
Thank you very much. I am curious about well, you were exposing very well, the terminology and how the condition or the disease can be mixed or called with a different name. How many actual diseases englobe the same terminology, etc., etc. But now, if I focus into children, as you say, JIA is until 16. Well, for me, that's a whole developmental heterogeneity there from birth until 16 years old.
Yeah.
What is the predominance age-wise in Italian groups? And do you feel you have the same pathology at different ages? And how can you relate that to the development of the immune system?
Okay, so generally, if the child start the disease in the very early age, like 1-2 year, it becomes more severe and it's hard to induce the remission. We have the more exacerbation. And this is probably how I can explain as an immunologist, because generally the regulatory part of the immune system is developing with the age. Yes, the newborns, they are quite good prepared to fight, yes, and to destroy the pathogens, but they are not well prepared to regulate this, yes. So, for example, we have frequently high fever in the infants or something like that, because they don't counteract to the immune response in the good manner. So it will be the influence. Usually, when the patient they are older, around this 15, 16, they still will be diagnosed with the GIA, but they looks more similar to rheumatoid arthritis, and usually they are not so severe. So there is easier to induce the remission or decrease the activity of the disease. And this can be explained with the expansion of the regulatory mechanism in the immune system. And also, for example, they are here also the B cells can be the key player here, because with the age we have the more memory, switch memory B cells, which are not so dangerous. Yes, they are not, they interact in a different way with the T helper cells, and they are focused on their job. Yes, producing the antibodies against the pathogen antigens. And in the young children, we have a lot of naive cells. And frankly say, in the infants, we have mainly the naive cells, which are also producing mainly IgM. They can react with autoantigens, but they can also react with the pathogens. And for example, activate the complement system, lead to the much intensive destruction of the cell tissue and exposure of self-antigens. So yes, usually the younger children are the more severe patient.
More questions? I have a few of them. Maybe I can just do two because of time. So just before going into GIA, just start explaining like rheumatoid arthritis, osteoarthritis, that we all call arthritis, right?
Mm-hmm.
But I think a few times I work on types of arthritis, let's say, the conclusion was the same. There's no treatment. So how would you impact a treatment by distinguishing between GIA, rheumatoid arthritis, if there is nothing? I think my feeling is that nowadays you just try and error, right? You have IL-1 beta inhibitors, P38 small molecules, but there's nothing.
No casual treatment.
Yeah, exactly.
Yes, we can only treat the patient and induce the remission. I can agree with you as an immunologist, as a preclinical scientist, as a doctor. I would like to have the more proofs even to the symptomatic treatment. Yes, because what problems we have in children. And for example, the companies do not want to put the new drugs in the GIA treatment, yes, and organize the clinical trials with the pediatric population. So if we have the more preclinical study, in my opinion, also the companies will invest. And this is our problem that, for example, the adult rheumatologists have a lot of monoclonal antibodies, anti-cytokine, and as a pediatricians, we don't have it. For example, if you want to use anti-IL-23 treatment, especially in Poland, we do this as off-label treatment. Yes, so it's our responsibility that we use off-label treatment in children. So if we find a casual treatment, I doubt it. Yes, maybe if someone really check the antigens and show, I don't believe it will be one, but some of them, maybe we'll be able to deliver some molecules, or never, for example, this protective antibody to protect the tissue. Yes, not block the inflammation, but stop the access of inflammatory cells to the source of antigens.
Okay. Okay. And I think you are not the first one coming here with showing some kind of connection between your disease, immunological or inflammatory disease, and the guts, the
Yeah.
digestive system. And for me, it's always the same question. I mean, what's first? Because you get a flu, and then your stomach somehow doesn't feel okay, and the other way around, your stomach is not okay, and then your immune system suffers. So, how do you reconcile this kind of thing? What do you think it's first? Or even the periodontitis, right? It's
Yeah. I think we underestimate the mucus-associated lymphoid tissue, and usually as a scientist and as a doctor, we focus on the examination of the peripheral blood. But the only true reason is because it's easy accessible biological material, yes? And we shall remember that in the peripheral blood, we can find only 10% of the immune cells, or they represent 10% of the representation of the immune system, while, for example, in the gut, this gastro-associated gut-associated lymphoid tissue, there is huge majority. Yes, the only gut, when we put the cells from our digestive tract, will have the organ almost 3 times bigger than spleen.
Okay.
Yeah. So, but this is the problem with the access. So for me, yeah, probably we can find the origin of the problem in the mucosal associated tissue.
But because of your sample is bigger, basically.
Yeah. And because everything started. Yes, usually the mucous membrane are the site which answer the face to the pathogen. Yes, because it's of the contact with external environment. Yes, and blood is the last. And blood is for me, it's just the highway for immune system, that they go from the lymphoid tissue to the affected tissue. So we have very narrow picture of this. But so I think when we go to the mucous membrane associated immune system, we can find more, and it will be before the condition. It can be the causative condition.
Okay, before the condition. Okay. I think we are done. If there's nothing else, just one practical question. So you have been working with synovial fluid, even from children.
Yeah.
I did so in the past, and it's a pain in the ass to collect it. People complain, it's painful, blah, blah, blah. How do you get the controls?
Okay, first of all, we never take the synovial fluid just for science. Yeah, and
so the controls?
From the GIA, we have we are lucky because generally the children symptoms are localized in the big joints, especially the knee. And the record of this myself, when I make the puncture of the joint, I retract the 100 milliliters of the fluid.
Wow.
And the hospital labs needs only like 5. Okay. So the rest is the waste. Yes, we need to utilize this, and the people, okay, if you put this to this red bag, yeah, you can take it. Yes, we never do the joint puncture in Chile just to recite something for science. And control. We have 2 types of controls, and usually as a control we use the post-traumatic synovial fluid. And it was crazy because usually when you have the post-traumatic patients, they are operated not in the plan way, or they are operated in this. But especially when I was working in Lubin, I had good collaboration with the orthopedics. And before they open joint for the surgery, they put of course, the patient agreed, signed the informed consent, and everything was according to the ethical instruction. But before they cut the synovial membrane, they put the needle and they take this post-traumatic synovial fluid. And also, if there is contaminated with blood, it was waste. Yes, so we want to clear synovial fluid. And frankly say, it was funny. I was a young PhD student, and for example, like Saturday 1 a.m., I get the call from my colleague, come to the hospital, we have synovial fluid for you. So I put my clothes on and go to the hospital, take the sample and cryopreserve the cells. And I have even such a call during my birthday. There was the party and they call me So I take to my guest, okay, let the party go on. I will be absent for the 2 hours. It was lucky I have the 400 meters from my flat to the hospital and to my department. Yeah. Yeah, I know it's not very good control, but nothing better. Yes, because osteoarthritis, it will be easy accessible. But now the papers show that some papers count the osteoarthritis also as autoimmune disease because this is chronic inflammation. So we collect the post-traumatic synovial fluid.
Okay, thanks so much. So I think we're done. Thanks a lot for coming, and thank you.
Thank you.